The traditional focus of hospitals has been saving lives. However, in recent years, hospitals have developed palliative care programs for those patients we can't cure. These programs focus on relieving pain and improving comfort. We'll discuss palliative care on this week's Health Talk. We're up next.
Hello, I'm Dr. Vicki Smitak.
And I'm Dr. Eric Mazer. Today we're going to talk about palliative care with Dr. Myra Skluth. She's director of the Palliative Care Program at Norwalk Hospital, and Iris Nagin, a nurse practitioner, also part of the Palliative Care Program. Welcome
Thank you
both.
for joining us today.
Thank you.
And this is a topic that can mean different things to different people, palliative care. How do we define palliative care so that we have a general understanding of what it really is as a specialty?
Well, the primary definition is it's for people with chronic conditions who are not going to get better, who have some limitation in their ability to do activities of daily living, like caring for themselves, washing, bathing, etc. And the primary mission is to relieve suffering. But it does not mean that a person cannot continue to have aggressive treatment.
So I was giving an example of diseases or disorders who would be encompassed by this palliative care program.
Right. I mean, people think a lot about cancer patients because, you know, while you're receiving active treatment, you have nausea, you have pain. So traditionally, people think about cancer treatments, but also any chronic illness that affects your quality of life and ability to function. So people with congestive heart failure, chronic lung disease, neuromuscular disorders, Parkinson's disease, are all good candidates for
But somebody with chronic low back pain or knee pain, that's a little bit different?
But those conditions aren't really life-limiting. I mean, if you have chronic musculoskeletal pain because you have a neuromuscular disorder, that's life-threatening. The other conditions maybe affect quality of life and possibly could be remedied by physical therapy or surgery, but it's not really what you think of when you think of palliative care.
Yeah. Also advanced dementia, because there's nothing we can do to make it better, but we can certainly do everything we can to try to improve your quality of life.
So improving quality of life and relieving suffering, that's really what I'm hearing, and that's, I think, a good way to sort of put this together for our audience. How do you get, so the team provides this care in the hospital or at the patient's home? It can encompass a whole range of different locations, is that right?
Well, this is a new program in Norwalk Hospital. It's only been in existence since April of this year.
Oh, so it's very new.
Yes, and part of it, of what we're doing, is educating our colleagues and the public about what we can do for them. So for now, the palliative care service is Iris and myself.
Okay.
I mean, we have a wider team, but they don't have as much time available. So
I was going to say, what kinds of things do you do for patients? I think it's very important because the traditional medical mindset is, here's a disease, I want to cure the disease or treat the disease. Right. And I think, in fairness, we as physicians have sometimes been distracted from suffering and focused on the disease. And palliative care is a way of reminding us and re-emphasizing the actual experience of being ill.
And treating the whole patient, which is something we talk about a lot on the show.
I think this is a wonderful movement that's happening. But maybe for our viewers, what kinds of things can you do to relieve suffering?
We try specifically to treat symptoms, so we treat pain, we treat nausea, itching, constipation, depression. That's just related to the illness, not chronic depression. But we also may talk to people about spending more time at home and less time in the hospital, which improves their quality of life. Or how perhaps we can revisit their medication list in terms of side effects. And whether side effects as opposed to the main effect, is the medication really helping you, or are you just getting side effects?
So for somebody who gets admitted a lot, for example, for pain management or for nausea, that's something that you can intervene on and help devise a better regimen, and that individual can then spend more time at home rather than in the hospital. I mean, that makes perfect sense.
That's perfect.
Yeah.
Right.
Okay.
I mean, the typical patients are the COPD and
Chronic obstructive pulmonary disease, kind of chronic lung disease
and
patients.
the congestive heart failure patients who are often admitted with shortness of breath, and we really and anxiety because of that.
So how do you say, how do you convince them to stay home if their shortness of breath is getting worse?
Well-
Do you give people tricks to deal with this or medicines to deal with
Well,
it?
we do. We often recommend very low dose morphine, which is a wonderful treatment. It's an old-fashioned treatment, but it does relieve shortness of breath. People are often very reluctant to take it because they say, I don't want to get addicted, but it's one of the best medicines at our disposal to relieve shortness of breath. And if patients can get on that chronically that have this, they may not have experienced those symptoms that are going to take them
And
back
the
to the
anxiety
hospital.
that's associated with that.
Mm-hmm.
Are people reluctant to accept palliative care? Do they think it means you're giving up on them, that you're not going to treat their disease?
I think most people, when you spend a certain amount of time talking about it, are actually very welcoming about palliative care. They have been, I think, waiting for someone to come and talk about how to make them feel better. Every once in a while, people do jump to the conclusion that it means that they're dying, that you're even talking to them about this. And sometimes you can convince them that they can look at it differently, and sometimes you can't.
You must also have buy-in from their physicians. I mean, it's a partnership with the primary care physician or with a hospitalist who's treating them, I would imagine.
Well, I'm glad you brought that up because often our referrals come from the hospital team.
Okay.
And the problem is, as a former primary care doctor, as many of you know, the office setting is so rushed today that people don't have time to have these conversations that they used to.
Right.
Then a hospital doctor is taking care of the patients when they come in, and we often are the first to really sit down and spend some time and have this discussion with the patient and their family. And usually patients are very grateful to have people to really spend time with them because everything in medicine today is rush, 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 rush.
It is, and we all feel that. So that's an excellent point. So you become that point person then for a lot of their chronic issues.
Right, and often we see the patients. We'll have a first discussion with them the first time they're admitted to the hospital, and then there are no decisions or anything like that. And then, because they have these chronic conditions, they come back again, and they see us again. And it's an ongoing conversation. And we often have family meetings, too, with the family, with or without the patient, depending on how, what the patient's mental status is.
Do you find that, from a patient standpoint, I can see patients who have unrealistic expectations of cure or medical intervention that's going to make things much better, or do you see more of the other side where people are going through the motions but are really delighted to finally have somebody say, we want to make you comfortable? Have you seen one more than the other?
I think you actually see more people who are relieved that somebody's finally discussed the 400-pound gorilla in the room. Somebody's discussed how they're getting worse and they're not feeling well, and that they actually have a choice about doing treatments and not doing treatments. Every once in a while you do meet somebody that definitely wants to focus still on aggressive treatments because we're all different. But a lot of people are very, very relieved that this topic is
because that was my personal experience. My dad, over 10 years ago, had not a chronic leukemia, had leukemia, was dying of leukemia, and was getting a series of different treatments to try to control it, and had developed osteomyelitis of the heels, which is an infection of the heel bone after surgery. And the only treatment for that was more surgery to get rid of that infected bone. And I remember having this, finally a discussion, do you really want this? And he was doing it for the family. We were going along with the surgery for him. And when we finally had that conversation about, you don't have to do this, you can go, you can die of this illness, he was tremendously relieved.
Yes.
But there was this lack. Nobody wants to really broach the subject with each other. The patient's trying to be brave for the family's trying to be brave for the patient, and neither is really getting what they want out of it.
And also sometimes the doctors themselves who've taken care of patients for a long time, they're very focused on the cure, and they lose sight of where the patient maybe is in reality. And so that's why it's really helpful to have people that they've never seen before come and talk and make an assessment. And once we've had these conversations, you asked me about this before, then we always let the primary care doctor know that we had the talk and what we discussed.
It must be a big relief to the primary care doctor most of the time that somebody else is helping with the management of these probably pretty complicated patients.
Well, it often is, but I think that's really important.
Sure.
Well, it's such a difficult conversation to have. As our viewers know, and you know, I used to practice oncology. And when do you reach that moment? Is it where you do sort of switch your orientation from cure or medical palliation, we'll treat that cancer so you feel better, to we can't really treat that cancer effectively much more, but let's really focus on your comfort. And that's really a evolving area, and yet you've got to make that decision in a discrete point in time.
Right.
It's complicated.
I mean, there's certain things you can look at if the patient has multiple hospital admissions in the same, let's say, 3-month period, or if the person is going to the emergency room a lot. Because they wake up, they don't feel well, they can't manage at home, they need to bring themselves to the emergency room. If the person's level of functioning is going down, so they were able to take care of things like washing and eating and getting around their house, and now they can't do that anymore.
So there's a list of things that you sort of go through, and I'm sorry that I know that's all the time we have for in this segment, but when we come back,
pick it
there are
up
some
after,
other really important components to this conversation that we still need to have.
So we'll talk more about palliative care after this short break. Stay tuned.
Minutes of physical activity a day and eating well can help get your child healthy. So keep them active and eating well every day. Get ideas, get involved, get going at letsmove.gov. That's letsmove.gov.
Oh, those boys are much too much. Those boys are much too much. We got the spirit, we're hot, we can't be stopped. We got the spirit, we're hot, we can't be stopped. We're gonna beat them and bust them.
The smallest moments can have the biggest impact on a child's life.
Let's get a little bit rowdy. R-O-W-D-Y.
Take time to be a dad today.
Oh, those boys are much too much. Those boys.
Bring out the action hero in you. Fuel up right and get energized. Be part of the greatest action movie ever. The first movie that puts you in the action. Show us how you train and eat like an action hero. Join in at actionheroalliance.com.
The first 30 seconds are all I remember. My doctor told me I had cancer. When the shock was over, I met with a cancer specialist at Norwalk Hospital. We weighed all my options: surgery, radiation therapy, chemotherapy, even the latest clinical trials. Their Whittingham Cancer Centre offered me personalised care, hope and leading cancer physicians. And I know great care. Besides being a cancer survivor, I'm also an ICU nurse, and I chose Norwalk Hospital.
Hi, Vicki and I are back with Dr. Myra Skluth and Iris Nagin talking about palliative care and palliative care programs that many hospitals have, including Norwalk Hospital. So we hear a lot about hospice, and we're going to address this question again at the end, but what is palliative care compared to hospice?
Palliative care does include hospice, but palliative care can take place any time during the continuum of a chronic illness, while hospice involves a focus on comfort care within the last 6 months of life. So you can choose to take part in palliative care and have a specialist come and talk to you about symptom management at the same time while you're receiving very, very active treatment, if that's what you choose. Or you can
still get your chemotherapy or radiation for your cancer, or your aggressive vasodilator therapy for your heart failure or whatever.
We had a man on hemodialysis while he was getting palliative care.
But it's really, again, a focus on the relief of suffering.
Right.
Which I think that word is wonderful, because we're not talking just about pain, are we? We're talking about emotional suffering, social suffering within the family.
Right, and I think as doctors we often lose sight of how much suffering sometimes these procedures that we recommend to people cause.
Sure.
So we try to look at the big picture, quality of life.
And giving people the permission, I think, in a sense, to say, I've had enough, or I don't really want that treatment, even though there might be other input coming to them that they should opt for it, right? Either from the medical community or from family or et cetera.
I've had several people express actual surprise to me that they can say which treatments they want and which treatments they don't want. That they can think about it and make a decision.
And especially since we're not saying we're going to cure you with this. By definition, these are incurable disorders.
Right.
But not necessarily imminently fatal disorders.
Right.
But perhaps not so surprising to your point, because I think, most people are trained to listen to their doctors, right? I mean, your doctor knows what's best, and if your physician is really, focused on curing you, which is a noble cause, don't get me wrong, but if the disease really doesn't really go along with the high cure rate, or it really is a chronic condition, then it is important for that patient to understand that they do have a choice in how much they want to do or not want to do.
And maybe we talked during the break a little bit about goal setting. Maybe you could talk, because I think it is looking at different goals than necessarily the cure of my disease or making me feel 100% well. And changing those goals really are part of the palliative care process. Maybe you could talk more about that, Myra and Iris.
Right. Well, one of the goals is we ask people, how do you want to be spending your life? Do you want to be in the hospital having medical treatments? Would you rather, be at home or outside in the sunshine, hanging out with your grandchildren or whatever? So then once they say, I really hate the hospital, I mean, as wonderful as Norwalk Hospital is, they say, I don't want to come back to the hospital.
Nobody wants to go to the hospital.
I know.
Right.
So then we try to work backwards and develop a plan to help them do that. And if they're depressed or anxious, as I said before, or short of breath, we try to recommend treatments. Constipation. We do review the medication list, because the more medicines you're on, the more likely you're going to have more side effects. Mm-hmm. I can't tell you, for example, how many people that are sort of in their last stages of heart failure who are still taking their cholesterol medicine. I mean, we know that's not going to really make a difference at that point in your life. That's a long-term preventive therapy. So we try to cut down on those pills, because people will say, I can't stand taking so many pills. What can you do? So we make recommendations. Mm-hmm. But we're only the consultants. We're not the primary doctor. We just suggest to the team or the primary doctor.
How about working with the family, Iris? Because family goals, sometimes family members and patient goals may be very different. Family members want the patient to fight. They want them not to give up. They want them to somehow, saying I want to be comfortable but not cured may seem like a coward's way out. Tell us a little bit about that dynamic.
We work with the families a lot, and every family is different, and every family has a different dynamic. And sometimes we mostly work with the family because we see a lot of people with end-stage dementia, and in that case we have to work with the family. But sometimes you'll have several family members who have all different sorts of opinions. And sometimes when the patient still can express the opinion, the family members differ in their opinions they want the family member to fight when the patient has had enough. And we spend, I think sometimes just spending time talking to people, listening to people helps a lot. And you have to explain to people that the patient really does get to decide how they're going to spend the rest of their life. And they get input, but the patient has the final decision.
So a lot of this must be done in within the context of the family. You must have family meetings and discussions.
We do have a lot of family meetings.
I would imagine.
But you also have to realize that the hospitalizations are shorter and shorter. And we're only seeing these people in the time that they're actually in the hospital. So there's a lot of work that still needs to be done, usually outside.
Do some palliative care programs extend their services outside the hospital and follow patients
Actually,
chronically?
Danbury is doing that, and ideally that would be, we hope to eventually reach that point. But part of the problem also is the Medicare regulations. Under Medicare home care, you're supposed to, they can give you care as long as you're getting better, but once they see that you've plateaued, you're not able, they have to discharge you. So now there's some pilot projects that they're trying to start so that under Medicare people can continue to get home care.
Because that sounds ideal, that you would want to have this service not only while you're in the hospital for 2 or 3 days, but really when you're home and you're really in need of it.
That's much more labor intensive, and we're a new program we're starting in the hospital, and maybe someday we'll extend it outside the hospital.
Do you have an example of a patient that you've worked with? I don't want to know anybody's personal medical history, but just to give us a real sense of what happens, a story about a patient and how this service has changed their course of their illness, or not their illness, but their experience?
We did have just because you're talking about family meetings, we did have a patient who was almost 100 years old, and until just before this hospitalization, this lady liked to go swimming every day. And
That's probably why she got to 100.
but her CHF suddenly became
Congestive
much
heart
worse.
failure for the people at home.
Congestive heart failure, I apologize. Her symptoms suddenly became much worse, and she became quickly oxygen dependent, and she had 2 hospitalizations back to back. So we discussed with her what she wanted to do, and then her son came in, and we actually had a family meeting. We brought her into the meeting in like a recliner chair that had wheels with her oxygen tank, and her son was there, and she had a home health aide that had been with her for years, and we had social work and spiritual care and our team and the medical team, and we all discussed the way she wanted to spend the rest of her life. And
did she choose to take the more palliative route?
Yeah, she chose the more palliative route.
Yeah.
And
That's a good story to end on, because that's all the time we have for on this, unfortunately. But what an important topic to cover.
We have maybe 20 seconds left. What's the message you'd like our viewers to take home with them from this?
That you have choices. That in your care, whether someone comes to you and says you have choices or not, you do have choices.
And palliative care isn't hospice. It's for much earlier in the disease process.
So I think it's expanding the kinds of services that help people, and it's wonderful that we're focusing on suffering as much as we are. So I want to thank both of you. We're going to ask Myra and Iris to stay with us. When we come back, we'll have today's health question.
Right now, let's take a look at some of our upcoming events sponsored by Norwalk Hospital.
first 30 seconds are all I remember. My doctor told me I had cancer. When the shock was over, I met with a cancer specialist at Norwalk Hospital. We weighed all my options: surgery, radiation therapy, chemotherapy, even the latest clinical trials. Their Whittingham Cancer Centre offered me personalised care, hope and leading cancer physicians. And I know great care. Besides being a cancer survivor, I'm also an ICU nurse, and I chose Norwalk Hospital.
Nice. No! Oops. Yeah, sure. Let's go.
Moms everywhere are finding ways to keep kids active and healthy.
Works every time.
Get ideas, get involved, get going at letsmove.gov.
Mom, can I have $1? Yeah, it's right. I think my purse is upstairs on the bed. It's not here. Check the dining room. No. What about your sister's room? It's not there either. The upstairs closet? The downstairs closet? There are no more closets.
Moms everywhere are finding ways to keep kids active and healthy. Get ideas, get involved, get going at letsmove.gov.
This week's health question is, what is the difference between palliative care and hospice care?
And we have our two experts here. We discussed it a little bit, but we want to emphasize that hospice is really an insurance-defined kind of care, isn't it? And palliative care extends beyond that.
Well, hospice, the doctor has to say that the patient's prognosis is 6 months or less. Not that there's a penalty if you live longer than 6 months, and many patients do, because once you stop some of their medications, they actually feel better. And good home care and good nursing care helps people to feel better.
And that doesn't get discontinued, just to put out there, if you're under hospice care and you happen to outlive the 6-month expectation, you keep getting hospice
right, there's
care.
no penalty, that's what I always say. But palliative care really starts way before hospice care. The problem is we get, too many of the palliative care referrals that we get are really hospice referrals, because it should be while you're still functioning, before you have like multiple hospitalizations and have spent your year or 2 years in and out of the hospital, you know, every couple months. That's when you see that someone's on that revolving door, then it's time to really think about a palliative care.
So that's a good
consult.
message for physicians and patients alike, to understand that this specialty exists and that it should be activated not within the last few months of a patient's expected lifespan, but really much earlier on,
and
to help with
patients can
symptoms.
ask for this too, can't they, Iris?
Yes, they can.
So you don't have to necessarily have your hospitalist say, let's see a palliative care consult. A patient or their family could say, I'd like to see palliative care. All we have time for is, so and there are many palliative care programs at other hospitals other than Norwalk. We mentioned Danbury Hospital. Many of the other hospitals in the region have that. So if you have a question you'd like to ask on Health Talk, please contact Vicki and me at healthtalk@norwalkhealth.org.
We would like to thank today's guests, Dr. Myra Skluth and Iris Nagin, for coming on our show.
Vicki and I will see you next week on Health Talk.